Order. Now call the Standing Committee on Public Accounts to order. My name is Kelly Regan. I'm the MLA for Bedford Basin and the chair of this committee. I would remind everyone attending today to place your phones on silent, which I have done. We're going to ask the committee members to introduce themselves, beginning today with MLA LeBlanc.
Good morning. Susan LeBlanc, MLA for Dartmouth North.
MLA Chender.
Good morning. Claudia Chender, MLA for Dartmouth South.
MLA Clark.
Morning, everyone. I'm Braden Clark, MLA for Bedford South.
MLA Barkhouse.
Good morning, everyone. I'm Danielle Barkhouse, MLA for Chester St. Margaret's.
MLA Young.
Morning, all. Nolan Young, MLA for Shelburne.
MLA Bain.
Keith Bain, MLA for Victoria of the Lakes, filling in for Tom Taggart, Colchester North.
MLA McDonald.
MLA Johnny McDonald for Hants East.
MLA Sheehy Richard.
Good morning. Welcome, everyone. Melissa Sheehy Richard. I'm the MLA for Hants West.
And I will note that officials from the Auditor General's Office, Legislative Council Office, and Legislative Committee's Office are in attendance today as well. On today's agenda, we have officials with us from the Department of Health and Wellness, Department of Public Works, Department of Service Nova Scotia, Nova Scotia Health, and Build Nova Scotia, with respect to the 2024 report of the Auditor General, Value for Money, Development of Transitional Care Facilities. I'm going to ask the witnesses to introduce themselves. I think we'll do the first row, then we'll do the second row, and we're going to start at the right, where we have Mr. Spinney.
Thank you. Derek Spinney, Vice President, Corporate Services, Infrastructure, and Chief Financial Officer of Nova Scotia Health.
Ms. Oldfield.
Good morning. Karen Oldfield, Interim President and CEO, Nova Scotia Health.
Ms. MacKenzie, Deputy MacKenzie, sorry.
Dana MacKenzie, Deputy Minister of the Department of Health and Wellness.
Is Chris Mitchell here? Yep. Chris? Okay. Chris, would you like to come forward and just thank you?
Good morning. Chris Mitchell, Executive Director, Strategic Sourcing and Chief Procurement.
Okay. Deputy Munro.
Good morning. Deputy Minister of Service Nova Scotia, Joanne Munro.
Deputy Hackett.
Good morning, Madam Chair. Peter Hackett, Deputy Minister of Public Works.
Mr. Jessome.
Good morning. Gerard Jessome, Chief Executive of Engineering of Public Works.
And Mr. Benoit.
Good morning, Chair, Committee. Dave Benoit, President and Chief Executive of Build Nova Scotia.
I'll do my very best to keep everybody straight. Thank you. I would like Deputy MacKenzie to make opening remarks.
Thank you, Madam Chair, and good morning, committee members. Thank you for the opportunity to speak to you today on this important topic. I'm joined today by colleagues from Nova Scotia Health, Public Works, Service Nova Scotia, and Build Nova Scotia. In 2016, the AG's office conducted an audit at the Department of Health and Wellness and Nova Scotia Health on the management of Nova Scotia's hospital system capacity. The audit found that the historical approach to healthcare delivery, with a heavy focus on hospital-based care, was not sustainable. It found that annual capital funding was not enough to complete urgent repairs on hospitals throughout the province, and slow patient movement within hospitals was causing emergency department crowding. In September 2023, the Auditor General issued a report critical of the department for long ambulance offload times and a lack of accountability and the impact on paramedics. Government agrees with all of these findings, and an important solution and an important part of the solution is more beds. When it's open, this transitional care center will help us reduce ambulance offload times and the resulting frustration felt by paramedics and other healthcare staff, and most importantly, patients. The center will help patients get the care they need faster and more conveniently, and help to reduce emergency department crowding. Value for money represents much, much more than just the appraised value of a building. We need more beds as fast as possible. Patients are staying too long in hospitals as they wait for long-term care or for the supports they need to return home. We know being in a long-term care facility or in your own home is a far better outcome. We need to make things better for these patients as fast as possible. So with that in mind, we also consider the value for someone waiting in a hospital bed to go home, but needs that extra step of support. We think about the value for someone who needs that hospital bed and is waiting for the care they deserve. Last week, the province, with its partners at Nova Scotia Health and Shannex, announced an innovative solution to provide more transitional care beds. As you may have already seen, Shannex approached the province with an opportunity to expand the existing project, bringing the planned second phase of care spaces to reality much sooner. The West Bedford facility will move in 2 parallel phases, moving up both project timelines. It will also help insulate these projects from much of the volatility in the labor market, as Shannex has its own construction and design company and is ready to deploy crews that are already available. This new arrangement will create a center of excellence for this innovative model, expanding the care pathways available, and, most importantly, opening more space to patients sooner. The patients who go to this new transitional care center will have access to services and care more focused on their specific needs, with supports to help them transition back to where they call home faster. The healthcare system is complex and interconnected. Issues in one area often have root causes in another. Investments in each area of a patient's journey help improve the overall system, to the benefit of all Nova Scotians. Action for Health is the roadmap to address these issues in a meaningful way, and this new centre will play an important role in our overall system. This is a new model of care and a new approach for Nova Scotia. We are, in fact, the first province in Atlantic Canada to move forward with this model. We're learning continuously and will iterate and evolve as needed. Before passing the microphone to my colleague from Nova Scotia Health, I'll close by reiterating Minister Thompson's comments in response to this report. Buying this building and using it to create a transitional care centre was absolutely the right decision. Thank you. I look forward to your questions.
Ms. Oldfield?
Good morning, all. Mr. Spinney and I are pleased to be here today to speak about solutions to the healthcare challenges currently facing Nova Scotians. Opening a transitional care centre in Bedford later this year will provide a model of care we have never before been able to offer for 68 patients at a time who would otherwise be waiting in hospital or be admitted to hospital before moving to long-term care. We anticipate many of those patients will in fact be able to return home rather than moving to nursing homes, and we know that that is where most people want to be. That's where they want to live, in community as independently as possible. And thanks to an innovative new collaboration with Shannex, we will see that number rise to 178 patients within 2 years. The challenges we face across the system are well known. Last year, the Auditor General highlighted, and I quote, that significant offload delays have become so prevalent in the healthcare system that they are the norm rather than the exception. We know other emergency patients also wait too long for care. After admission, it is not unusual for patients to spend part of their hospital stay in a hallway rather than in a proper room. Scheduled surgeries can be postponed due to a lack of beds for recovery after surgery. This only happens when there is no alternative, but it does happen. Hundreds of people who no longer need acute care remain in hospital beds for days, for weeks, for months, because we don't currently have a more appropriate place for them to receive the next phase of their care. Since January 2022, our overall inpatient occupancy has never been below our 85% target, and rarely even near 90%. In January, 2 months ago, it peaked at almost 109% of capacity. At times, occupancy in the Western Zone has approached 140%. That's the current state, and we know a large increase of population aged 65 and up is projected. That will only increase demand on this system. While this might seem like a list of separate problems to fix, they actually all do connect back to our ability or inability to move patients through the system. In 2016, Auditor General Michael Pickup examined the management of Nova Scotia's health system capacity, and he said at the time, and I quote again, "Change is needed. A new approach with less emphasis on hospitals and more focus on providing the right type of care in the right location is required." Today, together with the government and Shannex, we are delivering that change. By opening this transitional care centre with the intention of more to come in the future, we will not only create capacity in hospitals, easing pressure on emergency departments, on EHS, on inpatient units, but provide a setting and an approach to care that will lead to better outcomes for patients. The right type of care in the right location. And not only does this initiative make sense clinically and operationally, it makes sense financially. The cost of providing appropriate patients the care they need in a transitional care setting is substantially lower than caring for the same patients in a hospital. And the expanded Shannex project at the site significantly reduces capital costs of adding this additional capacity to our system. Whether we focus on patient outcomes or the bottom line, this is a case where, as the Premier has said, value for patients equals value for money. We look forward to your questions. Thank you.
Thank you. So now that we have concluded our opening remarks, we're going to start the first round of questioning. Each caucus will have 20 minutes, and then we will divvy up the remaining time among the caucuses. And we will begin first with the Liberal caucus. And just to let folks know, when your time is up, I will call order. I'm not being rude. I'm just making sure that everybody gets the same time. So I now call on MLA Clark.
Thank you, Madam Chair. Thank you, everybody, for being here this morning. I wanted to make one thing clear at the top here, which is that the issue of the Auditor General's report and the issues that I personally have with what has taken place here at Hogan Court is not beds, is not the outcome. No one here is sitting here and saying more beds in the system is a bad thing. That would be an absurd thing to say, obviously. The issue is that outcomes are not the only relevant matter in government. The process of getting to an outcome is also critically important, and that is the message in the AG's report. And I didn't hear very much about the process in the opening statements here today, so I wanted to ask a few questions about that because I think it's critically important, not only for this project, but for future healthcare projects going forward, which are in the order of billions of dollars, as the witnesses know. So the first point I want to make is around timeline, because I think there's some interesting things on the timeline here in the AG's report. The AG's report shows that on June 22nd, 2022, NSH signed a confidentiality agreement with developer A. And about 2.5 months later, on August 9th, an advisory firm completed a market scan of possible properties to convert to a transitional care facility. And I'll ask this question, there's a lot of witnesses, so I'm not positive who would be best suited, so I will ask the question and allow whoever feels they have the ability to answer it best to answer it. My question is, why would a confidentiality agreement have been signed 2.5 months before a scan was even done to figure out what properties were feasible for this site?
So I'll be looking for a hand, a nod, who thinks they're best to answer that particular question. Mr. Spinney.
Thank you, Madam Chair. The reason for the confidentiality agreement at the beginning was so that we could understand from developer A what they knew about the property and where they were in negotiations with the developer B, or however it's referred to in the report. So that was the reason, so that we could begin conversation with the developer that was already in conversation with the owner.
MLA Clark.
Thank you, Mr. Spinney. Signing a confidentiality agreement with a particular developer, though, ahead of time, does that not indicate a preference for that site before any other analysis had been done of other potential sites?
Mr. Spinney?
No.
No?
MLA Clark.
So then, I don't understand, to be honest. If it doesn't show a preference for that site, what does it indicate? And if why not sign confidentiality agreements with other potential sites? Why that one in particular?
Mr. Spinney.
Thank you, Madam Chair. So the reason was so that we could understand where they were in the process, and so that we could understand if this was even something worth considering go forward. And so the confidentiality agreements was simply an indication that we were interested in that. That's really all that references. And so it doesn't, every time you're looking at a property, you don't necessarily go sign a confidentiality agreement just because you're looking at it if you have ample information about the situation. And so for us, we wanted to explore further the situation at West Bedford. And so we signed a confidentiality agreement with the developer to understand where they were in the process.
MLA Clark.
Thank you. I also want to ask about the market scan there. From the AG's report, it says that a list of 17 properties in Central Zone, including Hogan Court, were analyzed, if I can use that term. It says included the year each building was built, its location, and the number of units. And this is what the AG said about the scan. We could not determine whether the list of properties contained viable alternatives, as there was no documented assessment of the properties against the established evaluation parameters. So how do we know that this was the best possible site if the market scan, according to the AG's report, did not have parameters in place to judge the effectiveness of the properties? How do we know that this was the best site based on that?
Mr. Spinney.
Thank you, Madam Chair. So what we wanted to do was to, exactly what you said, ensure that this made the most sense based on what was available in the market. And so we engaged through a consultant, commercial real estate brokers, to help us answer that question. What is available? And there was criteria. The criteria is in the report as well. There were 4 different criteria to determine what was available that could rapidly be turned into beds for the hospital system. And the commercial broker's response was, there are none. However, we can take a scan of the market to give you an indication of the kinds of buildings and facilities that are in the market that you could conceivably approach and see if that would be an option. Because even Hogan Court itself was not on the market for sale at that time. It was intended to be a hotel. And so through those 17 properties, 9 of them were apartment-type buildings, and they were at different locations in the city. And if anybody wanted to look them up, you could get a sense very quickly as to the state of that infrastructure. So those buildings were first created in 1960, 1970, and they were occupied. So the first criteria, being able to turn those quickly into beds, did not seem like a viable solution for those two reasons. And so there's been conversation about renovations required at Hogan. Well, you can imagine what they would be at a 1970 apartment building, for instance. They would be extraordinary. And at the same time, there were people living there. So even if we approached the apartment to say, hey, would you be interested in selling, it would be quite the transition to be able to do that. There was another 4 properties there of existing motels/hotels. Again, using the same philosophy that even West Bedford wasn't on the market, but it seemed like, hey, this is a good location. It seems like it could be renovated. We could make this really useful in the government of Nova Scotia. And so we looked at those 4 properties as well. And again, most of those were quite old and not easily adaptable, I'll say. So they weren't anywhere near in the state of West Bedford, which was in a growing community that had ample parking, that was close to the QE2, that was 70,000 square feet, that could quickly be adjusted because it wasn't finished. And then the other 4 properties there were hotels currently under construction. So more similar, if you will, to West Bedford. And in that case, those properties were with large brand names. I won't bother quoting them, but with large brand names and about to be going concerns, if you will. And so our ability to interact in that process and convince somebody that, hey, perhaps you'd like to sell to the government wasn't as quickly achievable as what we believed West Bedford would be.
MLA Clark.
Thank you, Mr. Spinney. Another question I have about the timeline here, which seems backwards to me. I'm not a procurement process expert by any means, but I'll lay this out, and to me it seems a bit cart before the horse. So on December 14th, 2022, government approves the purchase for $34.5 million, additional $15 million to cover renovation costs, so $50 million roughly. So government approves that purchase through Treasury, through Cabinet in December of 2022. About 5 weeks later, January 23rd, 2023, the government receives a report from an architectural consultant outlining some pretty significant renovation and upgrade work that needed to be done at Hogan Court in order to bring it to the standard required for a transitional care facility, obviously because it was designed and being built as a hotel. So why would government approve a $50 million purchase before even having that report in hand? And we're not talking about 6 months difference here. I know the argument is speed, but we're talking about 5 weeks over Christmas time, actually. So why not wait the 5 weeks to get that report so at least government has all the information they need before signing a contract with the developer? Why not? Why is that the sequence of events in that case?
Mr. Spinney.
I'm going to defer to Mr. Jessome.
Mr. Jessome will be coming to Deputy Munro's mic just for Ledge TV. So over one more. Thank you. Mr. Jessome.
Good morning. Thanks for the question. Yeah. So when Public Works became engaged, things were moving ahead very quickly. Right. We wanted to get in on the ground floor to kind of look at the building and get an overview of the gaps that we needed to fit our clients' needs, I guess. Right. So then we engaged NICM, who was a very a specialized consultant that knew a lot about healthcare projects. So we engaged them to kind of do an overview of the facility. They did identify some gaps in where where we'd have to bring the facility to provide that care that the NSH needed. But those gaps were all overcome, right? During the design process, during the schematic design process, using a team of consultants, experts, we were able to overcome all that gaps and get it to a good place that we would provide that care that was required.
MLA Clark.
Thank you. Perhaps this is a question for Mr. Jessome as well. I'm not sure, but taking that, is it the view of the witnesses that it's a good process to sign a $50 million contract before having that architectural work done? Whether, again, this is process versus outcome that I talked about off the top. Is it appropriate to sign a $50 million contract before getting that architectural report done, even though, as you say, Mr. Jessome, you feel like you've overcome those deficiencies? Is that a good process? Is that a standard process? Is that one that generally would be the way to do things, or are we doing things backwards in this case?
Mr. Benoit?
Thank you, Chair, and thank you very much for the question. I guess I would just go back to say that, you know, we had the approval to negotiate an agreement that didn't exceed the parameters that Treasury Board had given us. And so you have to go, like, it's if I could use the analogy, you wouldn't go and look at a house with your engineering architect until you have an agreement with the person who you're going to buy it from. And so this is, I think that's a really key element, is that it wasn't a blanket check or a blanket approval. It was an approval to go and have a discussion based on all of the research that Mr. Spinney had talked about, saying that this was most likely the best solution for this particular, in order to create this type of new facility.
MLA Clark.
Thank you, Mr. Benoit. Another thing I wanted to ask about was the issue of deed transfer taxes. So through this transaction, which was convoluted, obviously, a sale to a sale to a sale, the government paid developer A, I believe it would be, about $875,000 according to the Auditor General for deed transfer taxes and contract break fees. Is that standard practice?
Mr. Spinney?
Thank you, Madam Chair. It is standard business practice for businesses to recover their costs of a transaction. And so I would say that the answer is yes. It is standard business practice for a developer to recover their costs of a transaction. And in this particular case, that developer, part of their costs was to rightfully and dutifully pay the HRM property deed transfer tax. So it's a reasonable expectation that they would include that in a sales price go forward.
MLA Clark?
Thank you. Okay, perhaps it would be a reasonable expectation if developer A and developer B were doing this transaction as two businesses. I appreciate that. Is it standard practice for government to do that is my question. Have there been other circumstances like this in the past year or two, or is this an unusual thing for government specifically to do? That's kind of what I'm curious about.
Six minutes left.
Six, okay.
Deputy MacKenzie?
Thank you for the question, which is it usual for the government to pay deed transfer tax in situations like this? And in terms of being in an innovative situation where we're trying to acquire a property, to move quickly and have to acquire what is an appropriate building after the review of 17 different buildings, it was decided to do that as a transaction cost to facilitate this transaction.
MLA Clark.
Thank you. I'm still not sure, though, if is it unusual for government to do that? Is that something that is done often by government? Yes or no?
Deputy MacKenzie?
I would be unable to kind of respond that would be within the range of normal circumstances. But in terms of entering into transactions where a vendor's transaction costs or of a situation had to be dealt with, then I would imagine, and I'm speculating, that it would be within the realm of possibilities, yes.
Perhaps Mr. Benoit would be better to answer what the normal practice is. Mr. Benoit?
Thank you, Chair. No, I wouldn't add anything more than Deputy MacKenzie's already mentioned.
Thank you.
Thank you.
MLA Clark?
Thank you. And I wanted to ask Mr. Spinney, because I was at the press conference last week where you talked about the overall cost. I know that the Shannex is paying $46 million, I believe, is the price for the building and the land. And you said last week that your view is that government will, at a minimum, break even on that transaction. I'm just curious, just so I understand. So government approved the purchase of land of about 34.5 and about $15 million to cover renovation costs. So that's about 50. So I'm just curious, of the construction work, which is not totally complete at this point, I know that a different company was doing that. Is that $15 million going to be paid out in full to that company, or will some of that be held back because the work hasn't been done? I just want to understand the math of how we get to break even at a minimum. Thank you.
Mr. Spinney?
Thank you, Madam Chair. And so there was an original estimate, which is the 50 number I think that you're quoting, and at this point in time we hadn't spent all of that. And so that's why it's a number less than that. And so what we've done is we've taken an estimate of our current costs, and that's how we've created the $46 million negotiated number with Shannex to say these, and again, some of this is still confidential, so there's only certain numbers I can actually quote as we continue to negotiate with Shannex, but suffice it to say that that will cover what we've invested so far, and I'll say something more, because it's a reasonable expectation that there's cost recovery and profit.
MLA Clark?
Thank you, Madam Chair. I wanted to ask about the alternative procurements used in this process for construction management and other services. Last night, I was here. I know the Deputy Munro was here as well last night about the Service Nova Scotia estimates, and we were talking about a health and social services exemption for alternative procurements related to the MyHealthNS app. I'm just curious, for the construction management alternative procurement in this case, was that exemption used as well in this case, or what exemption was used to support the alternative procurement for Hogan Court?
Deputy MacKenzie?
Thank you, Madam Chair. We're going to have Mr. Benoit answer this question because it's a Build Nova Scotia question.
Mr. Benoit? Oh, it's Deputy Hackett.
I got to speak up once in a while. Thank you, member, for the question. Yeah, so in the construction portion of this, or the renovation portion of this project, it was done through an alternate procurement method. I'm going to let Mr. Benoit speak. I am going to let Mr. Jessome speak too about the process they went through, if you're okay with that, and how we chose the contractor to start that renovation process. So I'm just going to ask Gerard to step up first, if he could speak a bit to how that was chosen, and then and maybe Dave afterwards.
1 minute.
You got 1 minute.
Mr. Jessome.
Yeah, thanks for the question. Yeah, we so initially when we engaged the contractor to help us out with the project and coordinate the construction on site, the sale hadn't gone through, so it was confidential at that particular time. So we worked with our colleagues in procurement, and went through the alternate procurement process. We negotiate a deal with the contractor at that particular time, negotiate rates based on our experience, based on experience of the market, and we come up with a fair deal to move forward at that particular time.
Okay, there's 10 seconds left. Who else was going to speak on this? Mr. Benoit?
Thank you, Madam Chair, and thanks for the question.
Order. Afraid we'll have to proceed to the next caucus. So now we'll go over to the NDP Caucus. MLA Chender.
Thank you. Thank you for being here today, all million of you. I wanted to, I guess I'll just maybe finish this because I was listening yesterday in estimates as MLA Clark was asking these questions, and I don't think his question was answered, which is that we understand that there are specific exemptions that need to be followed when an alternative procurement is used. And I believe MLA Clark's question is which exemption to the traditional procurement process was used in this case for this alternative procurement. So if you could answer that question, that would be great.
Deputy Munro.
Thank you very much for the question. Madam Chair, I'm going to have Chris Mitchell step in to answer that question, specifically on Hogan Court.
Mr. Mitchell?
Thanks very much for the question, Madam Chair. So for this particular one, it started as a $400,000 alternate procurement for confidentiality, which I think we've already covered once. It was increased by the $10 million for additional deliveries against this one. I think what's important in this instance is the trade agreement and the sustainable procurement policy define actually limited tendering as alternate procurement in our policy, different language, but a similar context in the trade agreement. And what it means is there are times when the government is better suited not to go to market in an open and competitive competition. There are 23 circumstances which lay those out. I'm delighted to go through, as most of the deputies up here would know, happy to nerd out on procurement for you for as long as you like. In this particular instance, there was a competitive process followed, defined as the following. We utilized a standing offer which was already in existence over at one of the other public sector entities. It turned out that we weren't going to be able to utilize it directly to hire, but what we did was we took a look at the folks who were on that standing offer. We did some discussions with all of those companies, determined which ones were going to be available, and then subsequently came to the selection of the vendor who was awarded the contract in that situation. So it may not have been exactly the competitive process which would have laid out black and white all the way through. As almost 40 years in this process, everybody who's ever taught me told me, you don't live well in the black and white, you live well in the gray. And so if I was black and white, I'd be in finance. In the logistics supply chain world, there is gray. And so what we try and do, evident by the fact that we have awarded over 850 contracts this year through a competitive tendering process, worth just over, if you were here last evening, worth over just $1.35 billion this past year. The default for the government of Nova Scotia is to follow a competitive process. It is the number one, it is the best way to determine whether you're getting best value. But when things are going odd, the answer is you need to follow a process that is as good as you can or as close as you can to competitive, and that's what we did in this case.
Emily Chender.
I appreciate that. I heard this last night. We understand it was alternative procurement. I think in this report, the AG takes a different view of the standards that might need to be followed for that. But I'm going to ask the question a third time. So there are 23 exceptions. I don't actually want to hear what they all are, but I want to know which one was followed in this case. What was the exemption that led to, I understand that you're saying that it was better not to go to market, that that's the opinion of the department, but what exemption was used?
Sorry, Mr. Mitchell.
Yeah.
I have to call on you first. Mr. Mitchell.
Sorry, Madam Chair. So the answer is twofold. One is it began as a $400,000 confidentiality, so exemption number 2. The conversation with the OAG, I know because it occurred in my office, was we extended that under confidentiality number 2, based on the decision at the time from a timeline perspective of too early to still make it public knowledge at that moment. Conversation which ensued with the Auditor General was there are reasons why that could have been additional services, alternate procurement circumstance 15, or remain as 2.
Emily Chender.
Thank you. I appreciate it's a complex area, but for us, we're trying to kind of get our heads around exactly how this was followed, because it is, I think we'd all agree, an unorthodox approach. And so we're trying to get our heads around it. So I will just say that I agree with my colleague, and I'm sure I speak for my caucus when I say that we also are excited about the model. I think the model is exciting. I think we do need more beds. I think transitional care represents an opportunity. And, as someone who represents the area that includes the Dartmouth General, I know how many people are in alternative level of care beds in that facility, and how much happier and better they could be served elsewhere. So I want to be really clear about that, but as I think MLA Clark also said, we're not really here to talk about the model. We're here to talk about the process. And And so I guess for us, not having the information to nerd out on procurement, as I think Mr. Mitchell put it, what I want to understand is, there is an alternate universe where we build a building, and that building is a transitional care facility, and or we have a public procurement process and we buy a building, and the fire marshal signs off on it before the sale, and we don't have confidentiality agreements, and we don't pay vendor A for the bill of vendor B, and all of the things that are pointed out in this report. And so I guess we're trying to figure out, what is this compared to that? Like, why did we follow this process? So I guess I'm going to start in a really simple way, which is that when this model was announced, which we were excited about, we understood, I think there's two different, the Bayers Lake Transitional Care Facility that was planned was either going to have 195 or 200 beds. I think we've heard both numbers. I think 195 is the one in the report. And Hogan Court was going to have 80. So that would have been a total of 275 beds. Is that correct, originally, when the announcements were made? Because that's what I see in the press releases.
Deputy MacKenzie?
Mr. Spinney is going to answer this question.
Okay. Mr. Spinney.
Thank you, Madam Chair. And I may need help on this, but I'll start and see if others can support me as I go. But I think during the technical briefing, during the December 15th announcement, that it was 195 in total that were announced. 120 would be at the Bayers Lake facility and 75 at Hogan Court. But I stand to be corrected.
Mr. Benoit?
Thank you, Chair. And thanks for the question. I would concur that it was more like 195 total beds, 120 and 75, if I remember correctly. The system was aware, like the health system needs as many beds as we could get, so we were trying to get as many beds as we could get through these two facilities, as well as other parts. So again, the 15th December announcement wasn't just about transition care facilities, it was about the master planning for the whole central zone, and making sure that we get as many beds as many different places as we could.
MLA Chender.
Okay, thanks for the clarification. I understand the minister is shoveling dirt right now to break ground for the QE2 development, so hopefully that doesn't distract too many people from this room, but also is a sign of good things to come. Well, I think we've covered a lot of how we got here, and so now I actually want to ask about, because we now have a whole new negotiation and purchase and sale agreement to think about that is underway currently. And so I want to ask when the negotiations to sell Hogan Court to Shanex began. I understand from what has been shared that this was an unsolicited bid. Nonetheless, that is a conversation and a process. So can someone tell me when that conversation started?
Mr. Spinney.
Thank you, Madam Chair. We received from Shanex their unsolicited proposal January 23rd. So that's when they presented us with a document to say, here's how we think that we can expand on what we've started with you to increase to 178 beds.
MLA Chender.
Okay, thank you. And when will this be finalized? Because you alluded to some negotiations ongoing. So when would we expect that to be executed?
Mr. Spinney.
Thank you, Madam Chair. I would say that that'll be measured in weeks and not months, so I don't have a particular day, but that's where we are now. And so what has been approved is what we refer to as an early works contract, which allows Shanex to begin work, both finishing West Bedford Phase 1 as well as starting West Bedford Phase 2. So April 1st is when we would expect that they take over the construction site, if you will, and they begin doing that. In parallel, we are finalizing the agreements, and so it's a matter of weeks, I would say, not months.
MLA Chender, 10 minutes.
And that early works agreement, does that have a price tag?
Mr. Spinney.
Thank you, Madam Chair. It does, and so they have a limit of $20 million that they can spend through that agreement.
MLA Chender.
And those would be construction costs. They're costs of kind of getting started on the building.
Mr. Spinney?
Thank you, Madam Chair. Yes, the caveat I guess I would add to it is design. Some people consider that construction or not. So there's design work and construction, those types of things, yes.
MLA Chender.
And so is that then going to be deducted from the ultimate sale price? Like, is that up to 20 million a portion of the 46 million that's been agreed upon, or is this additional?
Mr. Spinney.
Thank you, Madam Chair. So the way that the transaction is envisioned, not finalized, but the way it's envisioned is that there will be a sale for 46, and then there will be an agreement through a per diem for likely 25 years, like the long-term care model, for 178 beds. So it's, if you can think of it, yeah, two steps where somebody pays 46, conclusion, and then a new agreement to pay a per diem to operate the facility for 25 years.
MLA Chender.
And so I'm just trying to kind of get the building blocks here. So that 20 million is separate from those two things, or is in the per diem category, is what you're saying?
Mr. Spinney.
Thank you, Madam Chair. Yes, it would be included in the per diem that will be charged, yes.
MLA Chender.
And so when would that $46 million be payable to the province?
Mr. Spinney.
Sorry, a little too quick, Madam Chair. We currently envision that to be when the entire facility is ready, which would be April 1, 2026.
MLA Chender.
Okay. And so you mentioned that the funding will follow the long-term, the kind of long-term care model, the per diem. Have those operating costs been calculated? Like, do we know what that per diem is, or kind of exactly what that structure will look like with any more detail?
Mr. Spinney.
Thank you, Madam Chair. And so, yes is the short answer. The longer answer is we're still negotiating it, so it's just premature for me to be able to actually say what the number is, because we may prejudice our negotiating position with the provider. But yes, that has been worked through and compared to other things, including, as it was noted in the AG report, our cost to do the same type of thing within the acute system, yes.
MLA Chender.
Right. So in the report, I think that cost was something like $544 per bed. Is that right?
Mr. Spinney.
Thank you, Madam Chair. So the 544 was the cost per day for what I'll call West Bedford Phase 1. So that was for the original 68 beds, for them, Shannocks, to operate those 68 beds, yes.
MLA Chender.
And so are you, I understand you're negotiating. Do we anticipate that this will be higher than that, lower than that, about the same?
Mr. Spinney.
Thank you, Madam Chair. It will be lower than that.
MLA Chender.
And so is it accurate that, so we understand that these early works numbers will be part of that, folded into that, so the construction costs will be part of that. Will the mortgage cost of the company also be a part of that per diem?
Mr. Spinney.
Thank you, Madam Chair. So all of the costs of the business that they need to recover to provide this service, I presume, would be in there. So in some respects, it's a question for Shannocks, although I would presume that they would have their costs of their capital in there, and that is expected, as it is in the long-term care model, to be provided. So in the 544 per day per diem cost that you referenced for West Bedford Phase 1, there is no capital component, if you will, because in that model it was owned by the province. And so in this particular model go forward, the 543 for the services, if I can call it that, will be less. And so there's economies that we're addressing in there. There is also capital costs like we pay in the long-term care model. And that's where I would expect that they're recovering their mortgage, yes. No different than what we would expect if we were a tenant in an apartment building or a business, paying rent at Scotia Square or someplace.
MLA Chender, 4.5 minutes.
Thanks. But it's fair to say that, so we know that if we owned the building, we wouldn't be covering those capital costs because they would be ours. We think that we may have a lower per diem based on efficiencies with this private company, but it's fair to say we don't really know that yet.
Mr. Spinney.
It's a fair question for sure, and something that we're going to be paying attention to, obviously, very closely. I would say that we're quite confident that we will, but one of the things that we need to take into account is when we look at that, and Deputy Minister Barbrick explained this quite well in February 13th public accounts session, where there's two envelopes of funding within these per diems. There's what we call a clinical one, and then there's an accommodation one. And in that clinical one, it's really a flow-through, where the province decides how many of what do we need to provide adequate care. So how many registered nurses, CCAs, et cetera, et cetera. And that way, we are guaranteed to ensure that people get the care they need, because we control that switch on and off as much as we want, and that's a flow-through. So although we have an estimate as to what we think is required, so we know how many FTE, I've got it precise by the types of different groups, we are going to be working and innovating with Shanex to make sure that that's the right number. Do we have too many of this type, not enough of these? And so based on our current expectation, it will end up being lower because there's economies of scale of having a larger facility. And then on the accommodation side, those are more administration type expenses and corporate services, if I can call it that way. So food services, porter services, discharge activities, those sorts of things.
MLA Chander, just over 2 minutes.
Yeah, I mean, I guess my real question here, I guess I'll ask a specific question, which is, did we actually do a cost-benefit analysis in terms of turning this into P3? Because, I hear what you're saying, and it makes some sense, although I have to think that the provincial government has the best economies of scale. We have the most employees. They are our employees. We have a direct line into them. So I'm just struggling a little bit to understand how moving this into a partnership with the private sector gets it built faster, makes everything cheaper when we have the biggest procurement, we have the most food, we have the hospitals, we have the staff. So yeah, so my question is, and I don't know, this is probably for Bill, was there a cost-benefit analysis completed? But my larger question is, why are we so sure the private sector can do this better?
Mr. Benoit, minute and a half.
Thank you, Chair, and thank you very much for the question. I won't be able to answer all parts of it because I'll just have to focus on sort of my area of responsibility. And I think one of the questions that you asked was, well, how can they do it faster? And I think Deputy MacKenzie had mentioned in her opening remarks that the company that's taking this on actually has their own workforce and their own construction agents. And so as a result, they're able to maneuver those. First of all, they don't have to go through a tender process in order to find sub-trades or main contractors in order to deliver on the project. And so they're able to maneuver that workforce where they need it and when they need it and how they need it. And so as a result, they're able to actually move more quickly on the actual build part for all different reasons, because they have a whole different model. As far as economies of scale, I can't speak for, obviously, Mr. Shannon. I wouldn't even try. I guess what I would say, though, is just from a casual observer, he's got a very broad portfolio, and he does. This is one of the things that they're known for. And so I'm sure that he also can affect economies of scale when it comes to materials and timing and being able to get...
Order. Time for NDP questioning has elapsed. We'll now move on to the PC Caucus and MLA Young.
Thank you, Madam Chair. And thank you for your opening remarks. And just piggybacking back on what Mr. Benoit said, like I spent my whole life in construction, and having your access to workforce, that is such an advantage for the project. I guess what my question is, and I'm just looking for simple language that your average Nova Scotian understand in your response here. I understand that with the announcement on Friday, the details of this agreement have changed. That said, I want to formally ask the department, why was this purchase done in the first place, and what is the goal of doing it so quickly?
Deputy MacKenzie?
Thank you for the question. In terms of the rationale for this purchase and the reasons for doing it so quickly, I've covered that extensively in my opening remarks, trying to be responsive to creating more capacity in the system to provide care, more beds for Nova Scotians faster. And I'm going to defer, Madam Chair, to have the rest of the question answered through my colleague at the NSH, Ms. Oldfield.
Ms. Oldfield.
Thank you. We've talked a lot about beds, and I know that the committee is well aware of our bed challenges, but I would be remiss if I did not talk about beds in numeric terms. I have to share, and I'm happy to table, this is StatsCan, our Department of Finance. I just want to talk about 40 years. The 20-year period from 1990 to 2010, we saw a growth of 37,000 Nova Scotians who attained age 65 and over. So in that 20-year period, 1990, 2010, we went from 112,000 over age 65 to 150,000. Let's take the next 20 years, 2010 to 2030. That 150,000 number doubles. It doubles to 300,000 Nova Scotians, age 65 and over. We're just hitting it. For every ALC patient we're able to discharge from hospital to a better place of care, there are probably 3 waiting to take that spot. So we do have a very, very, very serious bed crunch. There's no two ways about it. And it is the case that we do look for every single possible way to create beds. This past year alone, we've created 70 beds across our system. It doesn't sound like very many, but when you think about those numbers, every bed counts. We've created them using unconventional methods. At the end of the day, what this transitional care facility means, yes, it's an outlet. It is a bed outlet. That's great. These are people who have the very best chance of going home because the model of care, there will be RTs, PTs, OTs, people will be mobile. There is a kitchen where they will relearn or learn how to be able to care for themselves at home. Everything is set up to enable return to home. And that's where people want to be. So that was the goal, and that's what we've achieved.
MLA Young?
Yeah, thank you, Ms. Oldfield, for the answer there. I'll pass it on to my colleague, Emily MacDonald.
Emily MacDonald.
Thank you, Madam Chair. And just to add on to that, I mean, I've had some experience where previous to being elected, I had a family member who was in the hospital and then was deemed for long-term care. And it was 2 months. And that was 2 months that somebody else was in the ER or an ambulance was there with paramedics because there was no bed. So the point of whether it's 1, 7, 70, 195, everyone is going to benefit because every person that's in these facilities is one less paramedic that is held up at a hospital. It's one more person that gets through the ER quicker and in a bed. So I was the same as my colleague when at first. Why? And then I remembered, oh, I know why. Because the sooner we get them out of bed into facilities like transitional care, it's going to be better for the whole system, right? I mean, it's sad to say, I said it before I was elected, it's the most honest way is we need more beds to get them out of the hospital to free up everything. And it's not that simple. Oh, it's a simple answer. It's just not a simple fix. And had we started 20 years, 30 years, and every government, I'm not going to pick on any party because every party's been around and kept kicking it off. So when you wait too long, it costs a lot to fix it. Finished my ramble, Madam Chair.
It's your time.
In the previous auditor report, they talked about issues with ED overcrowding, which I just commented, and ambulance offloads. Can you explain how that's going to wind up helping increase access to flow through the system? And I will let whoever wants to take a hit onto it.
Ms. Oldfield?
Sure. Thank you. I think you actually just rambled into your own answer, which you used the word ramble.
It's John.
Sorry. That is the answer. So, we have people coming into the ER who are waiting for offload. They need to be treated, they need to be admitted. We have ED admits, those who have come through the emergency department and who are waiting for a bed. Those two things clog up resources, beds. We can't move them because we can't get people through. So we're working on all of it. This is not for today. We have seen very good and steady progress. It's for another day. We can talk about it. However, that's been the big picture reason why we can't. There are no beds to put somebody into when you have been admitted via the ED. So in the past, what has happened, and particularly around COVID, some things get to give. And what had been giving was surgery. So surgeries were either stopped or shut down or lessened or eliminated in order to free up beds. And that's certainly not fair to the person who's on the list or to the surgeon or to families or to the rest of the hospital. So now all of that's moving, but the difficulty is still getting people out the other end, particularly ALC patients. And I'm pleased that we have, I think, 3 or maybe 4 long-term care homes coming on stream in Central Zone in the summer and the fall. That's great, between 400 and 500 beds. But there's 700 there's 700, I think, across the system right now, ALC patients in a hospital system of about 3,000 beds. So we typically would run like 20%, which is a very high number. So we have almost 1,700 people waiting in community for a long-term care bed, which isn't even taking into account those waiting in hospital. So any bed we can find is what we can discharge from the hospital enables more intake at the front end, which is via the ER, and flow through the entire system. Hence, transitional care facility.
Emily McDonald.
Thank you, Madam Chair, and don't feel bad. They're used to me rambling and sometimes answering my own questions. So this is going to be for Nova Scotia Health. The Auditor General talks about the high number of patients in alternative care arrangements. Can you please explain what an alternative care arrangement is, the cost of the system for alternative arrangements, and the impact of these arrangements on access and flow?
Mr. Spinney.
Thank you, Madam Chair. So alternate level of care is in some respects just like it sounds. It's alternate from what a typical level of care required in a acute or hospital setting would be. And so an easy way to think of it too, and it's one of the definitions that we use, is medically discharged. And so the way that you can think about that is if you're or a loved one is in the hospital and the physician has said that you medically don't need to be here, you're medically discharged. And they actually sign off on that to say you're medically discharged. That means, though, that you still may need to go someplace. because maybe your home isn't ready to receive you, maybe there's renovations, that's the Home First program that the government has, maybe you're waiting for a long-term care home. In Central Zone, as of this week, I think there's 142 people waiting for a long-term care home. And just in the Central Zone, there would be over 200, I think it's around 216 people that are in this category of alternate level of care today. So that you need care of some sort, but you don't need it in the acute system. And so as we talked about, this all backs up and manifests itself in the emergency room. And so in the emergency room, for instance, as of the data that we received at 2 a.m. this morning, there's 19 people waiting at the Halifax Infirmary emergency room for a bed. They've been admitted and they can't get a bed, so they're in the hall. And at the Dartmouth General Hospital this morning, as of 2 a.m., there were 13 people waiting in the hallway because they couldn't get a bed. Now, I don't say that lightly because I actually take that quite personally because it's part of my responsibility to make sure that that isn't happening. So in some respects, I'm giving myself a bad report card today. But the point is that we need to be able to make space available so that they can go through the system, because it's those patients that actually need acute care. They were just admitted through an emergency department. But at the same time, elsewhere in Central Zone, there are 200 individuals that are not receiving the best care that they could be. And that's part of the answer here too. And so I'm really pleased to hear that everybody agrees with the model, that we can do better providing care in a different place, in a different way. And that's really what we're trying to achieve. And so one of the things, even through this process, we talk about cost benefit and these sorts of things. One of the things that does need to be taken into account, was taken into account, is how can we do this as quickly as possible in a balanced way. And so what we have right now is 68 beds. Before this most recent announcement, it was 68 beds at West Bedford. And 68 beds over 365 days is 25,000, roughly, just under. So that's 25,000 times in 1 year somebody's not in a hallway. And so for us, although there's financial things that we could get into too if asked, it became very clear that the value was there to Nova Scotians to be able to have something up at least a year earlier than it would be in other situations.
MLA McDonald.
So, Mr. Chair, I'll defer to my time to MLA Bain.
MLA Bain.
Thank you very much, Mr. Chair, and thank you for your presentation this morning. We know that there's a capacity problem within the whole system, and I was quite shocked when Ms. Oldfield mentioned about the Western Zone being up to as high as 140%. You know, that in itself is scary. And we know that the government and the Department of Health are trying to deal with this issue just by what we're talking about today. So I guess my question would be, what would the consequences be if we move into that constant overcrowding? You know, that the system cannot stand 140% or indeed cannot stand 100% overcapacity. So I guess, what are the consequences and what will this plan do to help solve some of those problems that are out there?
Ms. Oldfield?
Thanks. Well, I think we're seeing the consequences of being in a constant state of overcapacity. And I said at the outset, the holy grail of capacity in a hospital system is around 85%. And those numbers haven't been seen in Nova Scotia for a long time. And so, you know, there's many aspects of the consequences, but it all, at the end of the day, comes back to the patient. And the patient not receiving the care they should receive in the place they should receive it. the consequences that has on family members who are trying to pick up the pieces, the consequences on our healthcare workers who don't get their vacation, don't get their overtime, have all of those things, plus a pandemic in the case of, the last 5 years. So we are living the consequences, and our job, certainly mine and Derek's job, is to find the solutions, is to see that problem and find solutions. And that's really what we're trying to do. And everybody here is trying to do.
MLA Bain.
Thank you, Madam Chair. Just when you gave the figures before about the population over 65, that is an answer in itself, or it creates even more problems. But I guess the Auditor General in her report said this transition plan is good value for its money. I wonder if you could expand on that, please. It's a good value for the system, so if you could expand on that, please.
Mr. Spinney?
Thank you, Madam Chair. So you might be referring to the per day costs aspect of the report.
Ms. MLA Bain?
Yes, just the transition part of it, that it's good value for the money. So.
Mr. Spinney?
Sorry, Madam Chair. So yes, the Auditor General, I think, to put 2 points to what you're saying there, would have recognized the extreme pressure on the system in the report, and there was also reference to costs, or the value part of what you're paying for the different service. And so the average cost in the acute system, direct cost, would be about $975 per day, and that doesn't include the corporate services kind of thing. So this is going to be loose, but just to help us tie it together, that $975 would be closer to the clinical component of the model that we've been talking about. In addition to the $975, there's about another $275 that would be corporate services related, so housekeeping, management, these sorts of things, and we have that all broken down by the type of room or patient that you would have too. And then there would be capital costs on top of that. So you very quickly can get upwards of $1,400 per day. And again, that's an average. In this particular model, we can do something much less than that, and at the same time have people receiving a better level of care. So all of the T's that Ms. Oldfield was mentioning earlier, the OTs and the RTs, et cetera, those are the types of individuals, rather than the typical registered nurse, that really should be attending to these people. And so you're getting better, more customized care for a lower cost to taxpayers in Nova Scotia. So there certainly is value in that equation, yes.
Just over 1 minute, MLA Bain.
Thank you, Madam Chair. I'm going to give my colleague, MLA Barkhouse, a chance maybe to get the question in.
MLA Barkhouse.
Thanks, MLA Bain. I actually, 17 years, I think, around, minus having a couple children. I was in the healthcare profession, and I understand the bottlenecking of the beds 100%. Add on top of that, my ex, 5 years ago, was very ill and lived in the hallway at the South Shore Regional for a few months before we were able to get a bed. So I guess... well, geez, I only have a minute.
15 seconds.
Well, I guess I will wait till next round because I have no choice.
Okay. So now we'll move on to the Liberal caucus again, and we're going to do our second round of questioning, 9 minutes for each caucus. MLA Clark.
Thank you, Madam Chair, and obviously a lot of the discussion today has been around beds and the need for beds, and so I wanted to go back to something to make sure I understand it fully. I think MLA Chender touched on this as well, but in the AG's report, paragraph 1.82, talking about the proposed Bayers Lake Transitional Care Facility, which is not happening anymore, but it says the Bayers Lake Transitional Care Facility was originally anticipated to be a 200-bed facility. So if that was going to be 200 beds, and Hogan Court, as a one standalone building, which was the original conception, was going to be 68 beds, that's 268 beds. Now, under this proposal, what we have is 178 total beds on one site. So 260 to 78, that's less beds. That's 82 less beds. Do I have that wrong, or am I understanding this correctly?
Mr. Spinney.
Thank you, Madam Chair. I think we'll just take that away because it could be, we just need more information, I think, because like I say, in the technical briefing when it was announced, it was 120. I'm not going to try to ever say that we need less beds. You know, if there's another way to go get more beds, like put the highest number you can have on it. We just heard that we need over 700 for ALC patients in Nova Scotia right now. So I'm not sure that that's a typo. Maybe it's quite correct, so I don't want to say that it's a typo. But the way that we were approaching it was around the size of 120 in one place and 68 at another. But even now, when we're saying 178 at one place, this isn't going to solve healthcare in Nova Scotia. So we are continuing to look at what else we can do, and in the particular site at Bayers Lake, that we continue to look at options. It's just this, really what we're trying to say is that this first round, if I can call it that, of trying to get a transition to community facility up and running of this magnitude, this is how we're doing it. Yeah.
Emily Clark.
Thank you, Madam Chair, and I appreciate that. I just want to make the point that I think for the government caucus in particular to make the argument all about beds, 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 which is of course critical, as I said from the beginning. No one disputes that. And yet to see that potentially this might mean less beds, and maybe it means 178 in 20 months instead of 268 in 24 months, I don't know, and I don't think we have the answers to those questions, but I think it's an important issue to raise, and I just wanted to raise it because that is, that's not my speculation, that's what it says here in the AG's report, so I think that's a really important point. Another thing I wanted to touch on, going back to a bit of the procurement question, because this has been confusing to me over the last 24 hours, this health and social services exemption. So on page 30 of the AG's report, it says that the health and social services exemption was used for the $67.5 million operational contract for Hogan Court. And Mr. Mitchell, when he was talking earlier, talked about the 23 exemptions, and they're listed actually here at the back of the report, which is good. There's 23, as Mr. Mitchell said, but health and social services is not listed. So, and I know it's a new thing. Last night, the Minister of Service Nova Scotia was talking about how, you know, the criteria for this exemption, there's still some gray. We're working with legal, we're working with IGA to figure out how this will play. And again, this is another situation, I think, where sometimes in a mad rush to get things done, things are happening and it doesn't feel as though a lot of the legwork has been done. So I just want to get clarity on this health and social services exemption. Should we be using this for very large figures, $67.5 million, if it doesn't appear to be fully baked? Thank you.
Deputy MacKenzie.
Thank you for the question, MLA Clark. And I will begin, and I'm going to call on my colleague, Mr. Mitchell, from Procurement, our Chief Procurement Officer, to elaborate. And you point out something I think that is an interesting opportunity to clarify with respect to the health and social services exemption and the use of that phrase, and in combination with the actual exemption list, the listing of alternative procurement circumstances that the Auditor General lists. So the phrase health and social services exemption is a phrase that comes from trade agreements, and our procurement obligations in Nova Scotia, like most provinces and territories, derive from the fact that we are parties to trade agreements. The one that's most relevant here is the Canada Free Trade Agreement and CETA as well, the European trade agreement that we enter into. So that phrase, health and social services exemption, comes from those agreements. And I'll focus on the CFTA agreement, MLA Clark, because it is the origin, mostly that it is the paradigm that covers most of these things. And what it does is the health and social services exemption is actually taken by all provinces and territories across the country. And what it does, it reserves out of that which we must offer up for procurement, that which can fall under a health and social services exemption. So because it's taken so broadly, that phrase is actually embedded in the CFTA, and the actual exemptions that Nova Scotia has to carve out on an exemption basis under CFTA doesn't include that phrase, health and social services exemption. So when an entity like a government department or NSH is talking about the health and social services exemption, we're talking about the policy flexibility, is the word we use in trade law, to avail of that exception that is otherwise available to parties to the CFTA and CETA. So because we have that health and social services exemption, what happens then is every PT or provinces and territories, I apologize for the acronym, they then particularize those health and social services exemptions inside their own legislation and policies and procedures in the province. And in Nova Scotia, that finds articulation in our sustainable procurement policy and the list of alternative procurements that actually are there. So the exercise is one in which the parties who are procuring the actual good or service think about whether or not it is under the category of health and social services. And the services here, the provision of health services in a transitional care facility, clearly are. And that's something that's missing from I think a lot of the discourse on this, is that there was actually a lot of work. And, as we heard about the 17 sites being looked at, the actual procurement process or the process that was determined to choose the operator in this particular case. And what happens then is when the health and social services exemption is the territory that we are in, then procurement actually works with us to determine, under our sustainable procurement policy and our list of alternative circumstances, what exception do we avail of here? And as Mr. Mitchell will more fully explain that part of the process to it, and he's free to correct me.
MLA Clark, before we go to Mr. Mitchell, you have 45 seconds left. Have you heard enough on this answer? Do you have another question?
With 45 seconds, I'll just say that Mr. Mitchell can go ahead. I do think there's a couple other things I wanted to get to, but time is unforgiving, so I'll allow Mr. Mitchell. Go ahead.
Mr. Mitchell?
Thank
20
you, Madam
seconds.
Chair. In 30 seconds. So the question, two things. One is exemptions are not the same as alternate procurement circumstances. So alternate procurement circumstances are defined in both the trade agreement and the policy as times when you can use limited tendering. Exemptions is clearly articulated in the trade agreement, and it says for health and social services,
Order.
This trade agreement.
So we'll now move on to the NDP Caucus. You have 9 minutes. MLA LeBlanc.
Thank you very much. I just want to follow up on a couple of questions from the first round, but also make a couple of quick comments. And the first one is, in both Deputy MacKenzie's opening remarks and Ms. Oldfield's opening remarks, you both referred to Michael Pickup's Auditor General's report from 2016, I believe. And I just want to state the irony, or point out the irony, that sometimes we think Auditor General reports are great, and then sometimes they're not worth paying attention to. And it's particularly ironic that both of you quoted from Mr. Pickup's report about how bad the healthcare system was getting and the trouble that we were going to be in, or that we were in and we continued to be in. Totally agree with that. But the fact is that we are here today to talk about the issues that the Auditor General has taken with this process. And I just want to point out that I think that we need to, we need to be able to take that, those comments, and we need to be able to accept them and give a good reasons why we're not going to listen to them. So, and thus far, I've heard some good reasons, actually. Mr. Spinney, I appreciate your explanations on a number of those decisions and the way they were made. It's very helpful. But I haven't heard, I haven't been satisfied, haven't gotten satisfaction with some of the questions. So I want to go back, before anything else, I want to go back to Mr. Benoit. My colleague asked what the rationale was behind turning Hogan Court into a P3 rather than a purely public development. Was there a cost-benefit analysis completed? And if so, can that be tabled?
So, Mr. Benoit?
Thank you, Madam Chair, and thank you for the question. And I had, so part of that question was about how they could build faster, so I was working towards that. The government can, so we were in the process of trying to deliver on Hogan Court Phase 1 when the decision was made that we would move in a different direction. And I don't know, like, I wouldn't call it a P3 myself. I would call it like a private development now. Because they're going to take over ownership of the asset, they're going to take over ownership of the land, and they're going to develop it with their team. And of course, at any point in time, the government's able to make that decision, and should, based on the data and the information that they get. And I would hope that everybody would, based on data and information, make the best decision with the data that they have. And so, the unsolicited proposal came in through, it didn't come to me, and certainly I was supportive in the areas that we needed to provide information in order for them to make an assessment and a decision. And, but I mean, I don't have any other information in terms of, how that unsolicited proposal was evaluated. I do know that it was evaluated. And I guess that's all I would be able to provide specifically on that particular question at this time.
MLA LeBlanc?
Well, thank you very much. But just so you know, the Premier in question period yesterday referred to it as a public-private partnership. So maybe we should just check in with the Premier's office, or maybe someone who's on the Premier's health leadership team, and just find out exactly what we're talking about. Can anyone, does Ms. Oldfield want to let me know do you consider this a P3 project, or do you, as the Premier has suggested in question period, or do you consider it something else?
CEO Oldfield?
Thank you. I actually think that P3 has very specific legal meaning, and I would not be able to say it does or does not fall within that. However, what I would share is that we had an opportunity to partner with the private sector. A partnership doesn't necessarily, but could, be a P3. So I think the important thing here is the fact that we received the unsolicited proposal, signed by the private sector of seeing an opportunity that was evaluated, and it was determined to proceed with it. So that's how I would classify it. Thank you, Madam Chair.
MLA LeBlanc, 4 minutes.
Great. So I'm wondering if that evaluation can be tabled.
Mr. Spinney?
Thank you, Madam Chair. The short answer is no, and the longer answer is because we're negotiating that right now. And again, we can't prejudice the last bit. But did we do a cost-benefit analysis? The answer is most certainly yes. And the data that we have, the analysis we have, compares this extremely well to what we see in the long-term care sector. And so the analysis has been done. It has concluded that this is good value, and that's really why we're doing it. And I know that we're always talking about dollars, and I'm an accountant, so that's kind of my black and white safe space. But we can't talk about that without understanding what we're getting to. So we pay for something, yes, and we get a dollar value, but we have to then compare it to, but what did you get for it? And was that a balance? Yeah, did you get value for money, and not just how much did you spend, but what also did we get for it in return?
MLA LeBlanc?
Yes, absolutely. I agree with that completely, and that that's the crux of the Auditor General's report. That there's many signs that point to the fact that, and of course now we're talking about a different situation because things have changed. But before the sale of Hogan Court, we were talking about the issues with value for money. How much time, Madam Chair?
You have almost 2 minutes.
Yeah. So I guess I want to say. So first of all, again, Ms. Oldfield, in something you said earlier is that you said, like, we're doing all this, and this is what we've achieved. And I just want to point out that we haven't achieved it yet because we don't have this. It's not open. We thought it was going to open this spring. Now we have been told by the end of the calendar year. Again, this is not a criticism of the project itself. I'm just saying we haven't achieved it yet. The last thing I want to say is when somebody, either Ms. Oldfield or Mr. Spinney, talked about that your job is, as the helm of helming the Nova Scotia Health, is that your job is to find solutions. And I want to ask this question because I really do believe that people are wondering, is part of finding solutions, in finding solutions, are we giving up on public health care in Nova Scotia?
President Oldfield?
Thank you. Unequivocally, no. Unequivocally, no. Absolutely not. There are many examples of partnering with the private sector. There is no question about that. But there is absolutely no desire or wish or attempt to give up on the public system. On the contrary, and this is very important to me, our healthcare workers and our system is fundamental, and I appreciate and truly appreciate the work that they do every single day and what they do for Nova Scotians. So the answer is no.
30 seconds, MLA LeBlanc.
Well, I'm glad to hear that we're not giving up on the workers. That's not what I mean. I mean on the way our system is delivered. Because what I'm seeing is when it's easier for a private company to come in and it's faster and better value and all of that stuff, we're going to do it. We're going to do it quickly and faster, and we're not going to think about the unintended consequences of a chunk of our healthcare dollars and a chunk of our healthcare and patients being looked after in the private sector. And
Order.
so it's a valid
Order.
question.
The time for NDP questioning has elapsed. We'll now move on to the PC Caucus. MLA Barkhouse.
Thank you. Well, before I start with a few questions, I'd like to clear something up. I've heard at this table from opposition members a few times now that our caucus is they narrow it down to beds, Well, no, we narrow it down to people, which is our job as politicians, is to take care of people. And, I understand we look at this through this purchase, this process, everything through a different lens because we are part of government. And so we're not, flipping sod looking for worms to go fishing for gotcha moments, if you will. And so I just wanted to get that very clear because as somebody from the healthcare profession, I know 5 years ago, 6 years ago, whenever, I would have loved government to opened up beds and my partner would have not been in a hallway with a school bell trying to get some help, and I would have had to put my family, in the background in order to go up and do the CCA work, nursing work for him. So I just want to make that perfectly clear because I'm a little offended by that. So from my understanding, we already have transition care sites in several of our hospitals. I'd like to hear your opinion of how a standalone would deliver compared to the sites we already have.
President Oldfield.
Thank you. That is the case, and the existing TCUs, if you like, transitional care units, exist within a hospital setting. They are part of And therefore, the model of care is analogous to and is what is provided in an acute care hospital versus the standalone. And what will take place here is a very specialized group of professionals who can meet the unique needs of every patient coming into the facility. So I referred to the T's earlier, but the recreation therapist, the physiotherapist, the occupational therapist, those who specialize in frailty, and those who specialize in geriatric medicine. So people who understand the unique needs of community members who may need some specialized help to relearn something or learn something to enable them to live independently. And that's the primary difference, that we're able to carve and design, and in this case, co-design with our private sector partner, that specific model of care that is going to get people home faster.
Emily Barkhouse, 6 minutes.
And, thank you for explaining that. That's great. And it goes back to what Mr. Spinney had said earlier about value for money, because it is here. I mean, I don't look at it through an accountant's lens. I look at it through a healthcare provider's and now I'm not going to say politician, public servants lens. Also, we talked a little bit earlier about the Bayers Lake land. So I'm just wondering what the benefits could be for the healthcare system see as this land is freed up for possibility of new healthcare infrastructure, maybe?
Mr. Spinney?
Thank you, Madam Chair. The best thing about it is that it gives us the flexibility. And so we're always learning and growing and innovating. And so what we're now doing is through the master planning that we heard mentioned earlier, and there's the early works is kicking off at the Halifax Infirmary today. That's a large part of it, of course. And through the master planning, what do we need where? And so that was announced December 15th as well as part of the infrastructure plan, where we're looking at the Dartmouth General, what else can be done there, Cobequid, what else can be done there. And as we've talked about, originally that was the destined location for transition to community beds. Now that this first phase can be developed on one place through this partnership, that gives us the flexibility to re-examine that site to say, what's the best way that we could do that? We could still put beds there. We could still explore and create an urgent treatment center, for instance. So we've recently introduced that over the last year, urgent treatment centers across the province. I think there's about 7 now. Over 75,000 people have gone through those. So it's a great way to be able to get people away from the emergency departments. The emergency departments in Nova Scotia, the way that we track the people coming in is the what we call the CTAS level, or the level of acuity coming in. So 4s and 5s are the types of situations where we would rather have them go someplace else because it's not truly an emergency, but they may not know where to go. And so through the app and other ways, we've been able to divert people away from the emergency departments into things like the urgent treatment centers, so much so that our 4s and 5s going into emergency departments is down year over year. So we're seeing some good progress. So a long way, I guess, of saying that it opens up the door for us to be able to re-examine what's the best use for that particular property.
Emily Barkhouse, just over 3 minutes.
Okay. I'd like to not give a question, but give anyone on this panel the opportunity to just make a statement on, we're constantly at these committees, bam, 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 with questions, but to make a statement on your thoughts of this whole process and the benefits to have this Hogan's Court, if you will, for lack of a better term, have this in our healthcare system for our Nova Scotians that have years and years and years have been trying to find a politically correct way of saying suffering within the system due to lack of beds, due to lack of finances, due to lack and lack and lack. So
Deputy MacKenzie?
Thank you for the opportunity, MLA Barkhouse, and I will hand the microphone and the floor to my colleague, CEO Oldfield, on this particular item. I just kind of wanted to also address that, the statement made earlier by the member, MLA LeBlanc. We do respect the recommendations of the Auditor General. It's a really important part of how we conduct ourselves in Nova Scotia. So in terms of talking about this process and talking about all the due diligence that did occur and the processes that we're engaged in, we do actually respect, and we've adopted all of the recommendations that Auditor General Adair has made. And with that, actually, with the opportunity to talk about how this process will benefit Nova Scotians and its impact on the health system, I'll give the microphone to my colleague from Nova Scotia Health.
President Oldfield?
Thank you. I'm really excited by this. I think it is a completely new, innovative way to provide care to Nova Scotians. I'm very excited that we have a partner who sees the opportunity and shares the vision. When I mentioned a moment ago about co-designing the model of care, that's in fact what has happened over the past any number of months since this began. And, Shannex is excellent, known across this country. And I think what really makes me happy here is that they share what can be. And I do honestly believe, in my heart of hearts, this is going to be spectacular. Okay, it will be.
Order. Time for PC Caucus questioning has elapsed. We now have an opportunity for final remarks from Deputy MacKenzie and President Oldfield. Deputy MacKenzie.
Thank you, Madam Chair. I'd like to thank the committee for their time here today and their excellent questions, and my colleagues as well for their work and preparation for this event. And at the Department of Health and Wellness, we want to thank the Auditor General for her recommendations, and we're really excited to echo the comments of my colleague, CEO Oldfield, about the impact that this will have on the system and the many learnings that all of us can bring forward as we continue to innovate in service of Nova Scotia's healthcare system. Thank you.
Thank you. CEO Oldfield.
Thank you. To conclude, this facility will become known as a center of excellence for geriatrics. Things will happen there that we will look back and we will say, we should have done this long ago. I truly believe that. I'm very committed to making sure this can be as good as it possibly can for the people of Nova Scotia. Every single person here has worked really hard on this file, really hard, to bring it to fruition. And I want to thank each and every one of you for what you have done, in the back as well, and many others besides. I appreciate our partnership with Shannex. I really look forward to the innovation that will come. I'm proud of this. I recognize what the deputy has said and echo the comments. We are learning. We're going to continue learning. We're going to continue delivering for the people of Nova Scotia, and we will do that to the very best of our ability. Thank you.
Thank you. With that, our witnesses are excused. I am going to have a 3-minute recess to allow you to move swiftly out of the room, and because we do have committee business. The committee is in recess.
Good job, guys. Thank you.
Order. So the first item on our agenda is endorsement of Auditor General recommendations. This committee has a practice of endorsing Auditor General recommendations. I'm asking for a motion. MLA McDonald.
Thank you, Madam Chair. I move that the Public Accounts Committee formally accept and endorse the recommendation contained in the 2024 report of the Auditor General Value for Money Development of Transitional Care Facilities that have been accepted by the audit departments or agency, and ask that those departments and agencies commit to and take responsibility for full and timely implementation of the recommendations accepted by those departments and agencies.
Any discussion? All those in favor, please say aye. Contrary-minded, nay. Motion is carried. April 3rd, 2024, witness availability. All witnesses approved by the committee are happy to come. Some are not available. They may need to appear by video. Is there any concern about that? I think it was Deloitte and maybe Shoup. MLA Barkhouse?
Thank you, Chair. So may attend by video or will be attending by video. So either they're going to be here or they're going to be on video or they're
well, first of all, we have the committee would have to agree that they could appear by video. Okay. We have one person who is out of the country and the other person just simply isn't available on that date. Everybody's indicated they're happy to come to committee. So you have a choice here of come to the committee, do it without them, which I don't think is what we want to do, but that's up to you. You can, they can appear via video, or they can, or we can move it. Did I say move it to another date? Did I say that already? Yeah.
Okay. Yeah. Okay. It's just you said may appear on video, so I didn't know if you were. If they're here on video, I'm fine with that. I'm not saying that, but I want them to be part of that session or the meeting.
Yes. MLA LeBlanc?
Can you just tell us who it is, like so we know how to make?
Yeah. So there was an issue with Shoup and Associates and with Deloitte, and the Deloitte person will be out of the country. And again, I'm sorry, this just came to me last night, so I don't have a whole lot of details here, but they are happy to appear via video. Deloitte is. Shoup, I'm not clear on. They may send someone else. It may be a different person, but they will have someone there too, was my understanding. So do we need a motion? Okay. So in this case, could we just have a motion that those witnesses from Deloitte and Shoup and Associates may appear via video? Okay. Mr. Young has moved that. All those in favor, please say aye. Aye. Contrary-minded, nay. Okay. MLA Young.
Thank you, Madam Chair. I'm looking to speak to the correspondence that we have next from the NSTU. And, you know, this whole thing is unfortunate, the way this played out. I mean, of course I care about violence in schools. Of course we're compassionate to teachers. I have children in school. I've met with teachers. I have family that teachers. I've advocated for teachers. You know, it's...
So MLA Young, that's part of the discussion. So I just want to say we have two pieces of correspondence that have come in. One from, I hope I'm pronouncing his name right, Paul Lenarchik, and also one from Ryan Lutz, president of the Nova Scotia Teachers Union. Now I will open the floor for discussion.
Okay, just as I was saying, of course I care about teachers. Of course I care about violence in schools. I have kids in schools. I have friends that are teachers. I've met with teachers. I've advocated for teachers. In fact, I'm a former NSTU union member. You know, the facts of this are, and I got into this racket, believe it or not, for honesty and to have some integrity coming into the back end of this. And The Auditor General's report, and we've just accepted recommendations. In this instance, her recommendation for the report that I'll add, nobody has seen this report. I don't know the contents, Madam Chair. You don't know the contents. NSTU doesn't know the contents. We don't know what is in this report. All we know is there was a recommendation to have a witness provided by the Auditor General. And with that witness, we accept that witness. Will there be future opportunities for NSTU to voice concerns and stuff? Absolutely. We have lots of committees. There's lots of time, right? But in this instant, the recommendations are departmental recommendations within the school system. In fact, NSTU is actually meeting monthly with the department, and they've been doing that since December. Every month they're meeting to talk about the school code of conduct and safe and inclusive schools. These discussions are happening, right? So with respect to this Auditor General's report, the witnesses that they wanted for this one, there'll be many more meetings, there'll be many more opportunities. I just want to make this clear, because the way I'm seeing this painted is, we don't want teachers to talk. We don't want to hear from them. Of course we do. I still consult with them. I still hear them. You know, this is incredibly important, not only to me, but to our government, to the people of Nova Scotia. So I hope I'm clear that NSTU is talking with departments now. NSTU will have future opportunities. And for the contents of this report that nobody's seen that has to do with departmental recommendations, you know, it's not me picking the witnesses. This is the Auditor General whose recommendations we're accepting. Even 5 minutes ago, we accepted her recommendations. It's an independent body. So with those words, I just wanted to clear the record because I really found this unfortunate. Thank you, Madam Chair.
Thank you, MLA Young. MLA Clark?
Thank you, Madam Chair. I just want to say I respect MLA Young. I believe everything that he said about what's going on with the departments. Obviously, personal respect for teachers, no question. The one thing I will say is that, yes, we have not seen the report. It's the title, I don't know if I have it exactly right, is Combating Violence in Schools. The likelihood that that report and its contents will have no bearing or relevance to teachers is zero. It just is. I'm not a mind reader, but I'll make that prediction pretty safely. And whatever the practice of the committee, I'm the newest member here, whatever the practice of the committee has been, good, bad, or indifferent, I think we do a disservice when we say we're just going to keep doing things because it's the way it's been done, and that's the only justification. I don't think that's a good enough justification. If we were going to have a report about crime rates in Nova Scotia, it would be prudent to have police officers. If we were going to have a report about issues in the fishery, it would be relevant to have fishers. This is the same issue, the same exact principle. I am not trying to make this an issue of who likes teachers, who doesn't like teachers. That's not it. The point is, I would bet my bottom dollar that the contents of this report will have relevance for teachers who are in the classroom every day, independent of what's happening between government and NSTU, which I'm sure is happening as MLA Young has described. I just want to make that point. Thank you.
MLA LeBlanc, 5 minutes.
Yeah, thank you very much, Madam Chair. I mean, I also, you know, respect MLA Young and everything he's saying, and although I do feel like there's some sort of sense of like nefariousness going on, and like really it's not true. Like in subcommittee, we voted to have the NSTU as a witness, and then in the public committee, when that came to the public committee, I don't think I was here, but that was removed. The NSTU was removed by the majority PCs. And I just think that they should be here. And I have nothing to do with the fact that the president or this other gentleman have written to the committee. I've had no contact with either of them, but it is true that, you know, I have children in school, I have family that are teachers, I have lots of friends who are teachers, and we know that the members of the NSTU were interviewed for this report. And we hear all the time about violence in schools and how it affects teachers and how it affects, and this comes down to the public accounts, how it affects the dollars and cents. And I just think, like, it won't be a full conversation without them. Anyway, listen, I know that nothing can change. This is just a discussion. There's no motion to put on the table or anything. But I'm disappointed that there will not be if the government doesn't have any questions for the NSTU, great, fine, don't ask them questions. We just had 100 people here talking about Hogan Court. Why can we not add one more witness, or why did we have to take away a witness, pardon me, for this next discussion? Anyway, like I said, nothing's going to change. It's unfortunate. We have heard from union reps on many occasions at public accounts, and this is no different. Thank you.
Emily Young?
Just one other thing about this process, and the unfortunate process with how this committee sets agendas is through a subcommittee. And in subcommittees are in camera, and you can't talk about the things that happen in camera. And I can assure you that that what was recommended is what I would support. And if there's other external witnesses, and I can't say whether things, I got to be careful with my words here, but I can't say if the whole committee decided to go with the recommendations, even against the recommendations, but for that report, it was clear the content of the report was based on the department. And again, this is not an attack at the NSTU. Of course, teachers are a massive part of this entire process, but make it no different that in these monthly meetings that are happening between the NSTU and the department, would it be appropriate for us to say, well, that must include the Public Accounts Committee in every one of these meetings, right? And it really, you just hear me out here. And they are NSTU is definitely part of this, 100%. Teachers, 100%. Parents, 100%. But without even seeing the contents of this report, the witnesses that were recommended based on the one person that knows the contents of this report, and I believe even talked about who may not be appropriate, which I can't say who that may be for this current report. But just let the process go out here. Yes, we've had union people in committees and stuff before. Yes, we've talked about the issues. For this report, I think it's pertinent that we find out the contents, we find out the recommendations, we understand the report, and we all work together collectively.
Order. The time for this committee has elapsed. So I will just close with noting that our next meeting date is April 3rd, 2024, we report on the misuse of public funds at the Liberal Association of Nova Scotia. And if there is no further there is no further. We're done. I adjourn the meeting.